Assalamu alaikum and good evening. The topic that I will be presenting is femoral radial versus femoral axis and how ultrasound can help. I have no disclosure. And this is the layout. Why radial first? Do we have to abandon safe femoral in the era of radial first? How do safe radial and femoral puncture can be done? So why radial first? We can come across a patient with nasty looking aorta peripheral arterial disease. We can have a patient who is very much obese or the arteries are very much tortuous. But what if we have an average build patients with non-tortuous iliac and femoral artery? Do I have to go radial again? The answer is yes, because there are many other advantages of radial first. It can be clinical advantages because it has been documented there is less side bleeding and even there is less mortality in some of the trials, patient comfort, and there will be less hospital stay and less expenses by the hospital. Do we have evidence? Yes. We have trials like STEMI radial, Raffle streaks, Safari, in STEMI and rival matrix axis, and of course these were both in STEMI as well as and STEMI. All trials have shown that radial artery is better over femoral artery regarding non-cabbage related major and minor bleeding. And there is some mortality benefit as well, but it is controversial after the Safari trial. So this is the meta-analysis of these trials showing both in stable ischemic heart disease as well as in ACS and STEMI patients, the bleeding complications were less with radial as compared to femoral. And this is the comfort and less hospital stay. This is the radial lounge. They were sitting after the procedure quite comfortably, and after 4 to 6 hours, it was empty. Based on these evidence, the recent guideline has been updated. In patients with ACS undergoing PCI, radial approach is indicated in the preference to femoral approach to reduce the risk of death, vascular complication, and bleeding. In patients with stable ischemic heart disease, the vascular complication and bleeding will be less with radial. But should we abandon or forget safe femoral artery access? The answer is absolutely not. This is apolitical. Because the crossover rate of transradial is estimated to be 4 to 10%, we may need get patients with cardiogenic shock, and we need mechanical circulatory support, or maybe we need complex procedure and needs bigger guides. Those who are doing the structural heart disease, they need bigger guides and sheets like TAVI, EVAR, and some of the peripheral intervention. I think this video is not playing. Anyhow, it was for peripheral intervention below the knee, and the puncture was integrated because it can't be done from the radial. This was one of the cases, again, the video is not playing, in which our colleague was trying to do the radial, and there was tortuous subclavian, and we can see this, there was perforation, but we do the injection from the femoral. Thanks God, it was sealed. It was a small branch perforation. So how we set up for radial? The most important is that both the operator and the patient should be comfortable. What we have observed that most of our resident and fellows, they bend a lot, and they causing injury to the spine. So this is one of the commercial board available, how we should set the radial board. And this is for the left, this is for the left radial approach. Left radial, distal approach. So there are two types of radial puncture. One is the antegrade single wall puncture, and which once it is done with stainless steel needles. Once we see the bloods and we wire it carefully. Let me try this displaying. So this was the one of the left radial artery. It was punctured, interior wall venipuncture. So the double wall puncture in which the Teflon sheath is used, we puncture the artery in both the interior as well as the posterior wall. Once the blood is stopped, we retrieve the stellates and pull the Teflon sheath carefully. So do we need to use ultrasound for radial artery puncture? Yes, because this was a trial in which it has shown that the number of attempts were reduced if you use ultrasound guidance. First pass success was high with ultrasound guidance. Time to access was short with ultrasound guidance as compared to palpations. And in the difficult axis, which was defined as more than 6, again, the ultrasound was good. So how we set that this is axillary, we should keep the ultrasound at left shoulder. This is the video. We should hold the ultrasound probe in non-dominant hand. Identify the artery. It will tell us about the diameter as well as if there is any atherosclerosis or calcium. So we should puncture in the middle of the probe. We can see the dent. So this is a dose of anticoagulations to reduce the radial artery occlusion. It was a recent trial in which has shown that if you give high intensity anticoagulation during radial artery, during diagnostic, the radial artery occlusion was less, and it is 100 international units per kg. How we can do the safe femoral puncture? It can be done by palpation in use of landmarks, fluoroscopy, ultrasound guidance, or we can use the hybrid in which ultrasound guidance plus fluoroscopy is used. And this was the trial which showed that if the ultrasound guidance is used, overall success was more, both in obese, peripheral arterial disease, high bifurcation, only 2 minutes. Against the number of attempts with ultrasound were less, first pass success was high, venipuncture was less with ultrasound guidance. There was less hematoma seen with ultrasound guidance, and this is how it is done. I will show the video. So again, the ultrasound probe should be held in the left hand or the non-dominant hand. First, we should do the longitudinal to look for the bifurcation. Then it is turned for the short axis, and once we identify the artery, and if there is no calcification, we should puncture it just above the bifurcation. So don't forget at the last, if you are doing, especially with the difficult femoral, to inject the femoral sheath through the femoral sheath to look for any injury of the branch. So the take-home message, transradial access should be the default access route for ST segment elevation myocardial infarction and ACS patient, but the operator should become experienced with non-emergent transradial approach PCI prior to performing STEMI transradial approach. And contemporary, if you use contemporary technology like ultrasound and hybrid approach, ultrasound plus fluoroscopy, femoral approach is mandatory and safe as well. Operators should develop proficiency with ultrasound guidance for facilitating vascular access. Real-time ultrasound guidance should be available and used when difficult radial or femoral access is encountered or expected. Thank you very much.
Thank you very much, Dr. Jabbar. We are running short of time, so we are just starting the session 2, and I would like to invite Dr. Noor Tastakir to conduct the session. And I would like to thank all the worthy panelists and all the worthy speakers for their excellent talks. Thank you very much. Dr. Noor Tastakir to moderate the next session on interventional pharmacology and the precision PCI. Thank you very much. Thank you very much.